I'll hand over now then to Gabbie, if that's all right, Gabbie, who will give us a kind of provider perspective on behalf of the CNEN. Thank you, Gabbie.
Good afternoon, everyone. Thank you so much for joining. I don't know about you, but I found it as a district nurse myself and as Queen's nurse already this afternoon. This just feels like music to my ears. It really is validating and supportive to know that this is a national picture. And going on from that, I'm here to represent the Community Nurse Executive Network, which is hosted by the QICN and sponsored by Hallam Medical. I've just put the link to the CNEN in the chat. It's a free network for sort of exec level nurses or their equivalents in community healthcare providers, where we share and learn about the latest developments, trends and issues relating to workforce education policy, service planning. We have some really good speakers come, and we also do a lot of work helping those speakers understand community nursing and some of the issues we've heard about today. So please do look into joining if you can. So we did this presentation for the first time last year, and I haven't repeated everything, so because otherwise it would be the same presentation again, really. I've done some the same and compared it and put in some aspects that are specific for this year that the group has put forward. So this is a slide from last time that we met, which shows that we have a real capacity demand imbalance in district nursing for various reasons. And that leads to the capacity demand gap, which to some extent providers are beginning to be able to demonstrate through the community nursing safer staffing tool, which has now been relaunched with Mark II. Where you have that gap and you can't meet all of your demand, you prioritise your patients in some way, from the most high priority to the lower priority rather than low priority, and allocate those higher priority patients for a visit first. But the rest are then deferred or cancelled or on a waiting list, and that can lead to harm and does lead to harm. So our members are really feeling that this year that has worsened. For example, in one provider, we're looking at about a 30% capacity demand gap, roughly about 1,000 to 1,100 visits a day from that service, and deferring anything between 300 to 700 additional patient visits that were due that day a day. So really big numbers we're talking about. And of those deferred patients, around 100 a day are in the high priority category, often people with wounds. And we really are seeing harms as a result of that. And we've talked today about the effect of this on the whole system, where district nurses for some time haven't been able to do their full preventative role or use all of their advanced skills that we've talked about today because they have to go more task orientated to try to cope with demand. That has a big knock on for patient safety and to the whole system, hospital admissions, and it's really showing the economic value of district nursing that we've seen a lot today. That's hard to do but needs to happen. So a bit worse on that front this year. This is something we looked at last year. What are the national challenges? Well, they've sort of stayed the same. Lack of investment, and we know from the Darcy report and everything that's come since that we've had a long-term policy of a left shift of demand out of hospital setting into the community, but it's not been matched by resource. Nursing shortages continue to be a problem. We've heard about fragmentation today and about how Steph was talking about, investing in those core services. District nursing is an absolute core service in health and social care. And when you start breaking that up and fragmenting it, you just create duplication, inefficiency, and lack of continuity of care. We're particularly seeing that around end of life care in some areas, sometimes frailty services being set up and not invested in district nursing, and also that division of health and social care that we've had for a very long time. We'll hear some examples of some of the things that have been going on as a result of that division. The digital interoperability gaps that we've had for a very long time persist and, don't seem to be getting much better at the moment. That really hampers what we're trying to do, particularly when you're out in the community and you need access to other sort of pieces of information about that patient to do a holistic work with them. And one thing we've really found, the public understanding and expectations has changed since COVID, particularly, and that public attitude and behaviours has changed since COVID, and that seems to be getting worse year on year. We'll talk a little bit about that going forward. So this is something just to pick out a few things about this year that's different. So this isn't supposed to be a complete picture. It's just picking out a few things that our members have talked about when we said we were doing this presentation. So a huge increase in insulin administration visits over the last few years and rising and looking to rise in the future. At the moment, anything with our members between 24 and 44% of the caseload and visits you're doing a day, which also leads to real pinch points during the day, because often they're due at certain times associated with meals, often early-ish in the morning. So it really leads to pinch points. More deprivation that we're seeing out there in our communities, and obesity, which means we're having a lot more younger people on the caseloads in general, but also needing insulin administration who can't manage it themselves. Where we're trying to do some delegations to care homes and domiciliary carers, it's not very straightforward and requires a lot of effort and governance to train them, and then the turnover of staff there means that sometimes it doesn't sort of give you the efficiency that you're looking for there, or the continuity for the patient. And some areas, care homes and domiciliary carers saying that they don't want to accept that delegation. That's not something they want to accept responsibility for. And then in general, other services and the impact of what's happening in health and social care, increasing the pressure on district nursing. So all services are under pressure, and more you see that protective, defensive working to try and protect their own capacity. So the silo sort of becomes bigger when we should be really trying to integrate more. The GP collective action that's happened in the last year or so, that has been different across the country about what GPs have chosen to stop doing. In some areas, they've stopped doing any wound care. In other areas, it's things that have less impact on district nursing. But in general, what district nurses are seeing is more ambulatory patients that have nowhere to go and end up being picked up by district nursing. Although this isn't necessarily the core work of the district nursing service. And also what this means is that sometimes those patients can be, because of the nature of their care needs, might be prioritised over people who are truly housebound and maybe more like the core work of the district nursing service, who can't get their care from anywhere else and can't go anywhere to any alternative to get anything else. So I think it has a disproportionate effect on the housebound people. And there's not a parity of esteem. Another example of this was around mental health services criteria being quite strict. So patients who clearly have issues around their psychological and emotional mental health, not being able to access services because they don't have something that fits the criteria, or they're discharged from services at an early stage. And often district nurses finding that they're left holding responsibility for patients in quite an isolated way in their own homes, and that lone working, where you have to be a decision maker and hold that risk. without the correct skills to do that for patients. And that can lead to real poor care for patients, but also real stress and wellbeing issues for nurses. Another thing we've seen is social carers who are actually pushing back on delegations that we have previously been able to give to them, things like oral medication administration or changing urinary catheter leg bags. In some areas are being passed back to district nursing, which is really increasing the pressure. So let's see if this will work. Oh yeah, here we go. So different things that are challenging and that we're seeing in the last year particularly. It just seems like the challenges and complexity of our district nurse caseloads are going up. So we've talked a little bit about the public expectations of the service. We're seeing a real increase in complaints from patients and relatives, often related to deferrals and cancellations and waiting lists, but also sometimes some unrealistic expectations of what a district nursing service could provide. We're seeing much more aggression and violence towards district nurses on visits from patients, from relatives, so within the home, but also from neighbours. And in my trust, we've recently had the first ever successful case where a member of the public who was nothing to do with the district nurse visit has been successfully prosecuted for their aggression towards a district nurse who'd parked somewhere they didn't like. So those sort of examples really increasing. We've seen that since COVID, but really more so in the last year. We're also seeing a lot more racism towards staff and patients refusing certain staff from different backgrounds. And we've seen generally in the community, obviously recent upsurge politically from the right and public displays of patriotism that is maybe allowing people to feel that that's more acceptable. Substance misuse seems to be a real issue that's increasing. Undiagnosed neurodiversity, so people that have potentially symptoms or traits of particularly autism that we're seeing where they may need more support and more understanding about how they are managing life, and there isn't the support out there for them, and they're not diagnosed, so they don't qualify for anything, and even if they did, there's huge waiting lists. District nurses really holding some extremely complex cases relating to safeguarding, self-neglect, behaviours that are very challenging, and just absolute lack of advice, support for the patient or the district nurse to cope with that. Really seeing an increase in that. We've said social deprivation and poverty is increasing in this country, and that's having a real knock-on to our caseloads. Younger people that we're seeing who are frail at a much younger age because of that. Living conditions deteriorating, so those environments that district nurses are going into being more risky, and also with more substance misuse, shared households or buildings where there's that type of thing going on is posing a risk to district nurses. Some district nurses are going in pairs on a lot of visits because of these safety issues, and some are even employing safety security guards to go with the district nurse instead, because the risks are so huge. Lots of people making unwise choices, even though they have mental capacity, and a real sort of binary attitude to whether someone has mental capacity issues or not, whereas actually it can be more nuanced than that, that actually, although they may have mental capacity to make a choice, they don't have the processing skills or mental capacity in order to carry out that choice. So that goes back sometimes to some of the undiagnosed neurodiversity personality disorder things, which mean you get more court of protection type of complex mental capacity cases. Self-neglect seems to be getting worse, more court of protection cases, more coroner's inquests, and they seem to have a disproportionate time-consuming nature to the reports and the input that you have to make to those coroner's inquests. And generally, this sort of complexity is really time-consuming, and because of that, it takes up a lot of capacity in the district nursing service. Other services are less willing to get involved with those patients or attend multidisciplinary team meetings to try to discuss and support each other with those patients. And ultimately, whilst that causes stress for those patients and staff involved, also the other patients on the caseload, we have to defer more because we're spending so much time on this sort of these sorts of issues. Some providers reporting that staff are feeling unsafe in going in the community into people's homes, and they're looking for jobs now, not because they don't love the job, because they do, but they just don't feel safe doing it out in the community anymore, and are looking to go into hospital environments or outpatient type environments where it's more protected. Oh, and the other thing is filming of district nursing on visits. So many people have Ring doorbells now, have in-house cameras, and relatives may be remote to the patient. So yeah, a real increase in that, which makes people feel very uncomfortable and unnatural on the visit, and you're questioning why somebody is filming them. So we now have our NHS 10-year plan, and you know, what's the potential around this? So it's reactive to proactive care. So as we've heard in the benchmarking results, self-care promotion is something that district nursing services in general are really trying to focus on. There's quite a bit of work on NHS Futures, different people looking at that. Neighbourhood teams, going to talk a bit more about that in a moment, but there's real opportunity for district nursing there. The shift from hospital to community care. There's examples of sort of red card systems which go through the whole system for the patient, so that if there's been unacceptable behaviour in one environment, that red card system, like in football, goes through to the next environment, and it's accumulative to sort of put those boundaries around behaviour. Neighbourhood teams, again, hospital to community care. The analogue to digital shift. One example is the upsurgence of wound care technology, so wound management apps, which were recommended as part of the National Wound Care Strategy. More and more services are starting to use these, and are seeing in general a reduction in the time it takes to assess a wound. Therefore, it's assessed more often. You spot poor healing quicker, and you do something about it, which then leads to an increase in healing rate. So that'll be interesting to see what effects that has. So looking at neighbourhood teams as one example of what the future year might hold, district nursing has a unique skill set around neighbourhood teams. Population health is part of the district nurse specialist practitioner qualification. Case coordination is a big part of district nursing. Those advanced skills we talked about earlier, really useful to be able to do comprehensive geriatric assessments and prescribing or de-prescribing. That holistic approach, which many of the services that have been set up that are similar to district nursing could have been incorporated into district nursing, often are more interventionist in nature, and one of the only true holistic services that you see with people that are trained in a holistic approach, being staffed by people that have been trained in that approach, is district nursing. Real focus on that secondary prevention, which is what neighbourhood teams are all about. And we have those unique relationships as well with primary care, although that has deteriorated in many cases because of the pressures on both services, who share a lot of similarities. Also, the lack of space in GP surgeries, meaning that district nurses have had to move out into remote offices and don't have that sort of more natural linkage with the GPs. But still, there is that unique relationship, and we need to build on that and really collaborate with primary care and district nursing together to influence how neighbourhood teams develop. We've got that unique relationship with patients and families, often over a long period, and you're going into somebody's own home, and it just really makes that therapeutic relationship very different to many other services. So there's a real potential for a key leadership role for district nursing and neighbourhood teams. And it's disappointing to find there's the real lack of investment in the rollout of proactive care and neighbourhood teams compared to the rollout of urgent care response and hospital at home and things like that. Certainly district nursing and primary care services seem to be saying that, yes, neighbourhood teams, integration, lack of duplication, all of that stuff's great with a community focus on your population. However, it's very challenging to know how you will achieve that given the lack of that sort of pump priming investment to do something a bit differently when you're already really struggling, as we've just described. So potential, but challenging is the summary. Thank you.
Thank you, Gabbie. I think lots of people commenting about how this really resonates with them and what they're seeing in their patches as well. And I think someone saying this really summarises what we are seeing, and it's so helpful to have a list like this to help demonstrate the changes and the challenges in summary. But yes, lots of comments coming through saying about things like the Ring doorbells, things such as traffic incidents, dog bites, aggressive behaviour from patients and relatives. And then there's been quite a bit of discussion around the safer staffing tool as well, which we can maybe pick up on in a second. But yes, lots of people saying thank you, Gabbie, for kind of the reflections.
Well, thank you to the CNEN, and if you found that useful, please do look about whether your organisation is part of that yet. It's free to join, and please use the link because it can be a really supportive group where we talk about these sorts of issues every time we meet and share tips and good practice to help each other.